All right, good evening, everyone. Um, Welcome all to the Brain Health and Wellness series. Tonight, our speaker is Dr. O'Toole, and she is presenting on improving the control of the seemingly uncontrollable in dementia care. My colleague, Nicole Hale, and I are pictured here, but my name is Hannah Doles, and along with my colleague Nicole, we provide care navigation in the JFSA Dementia Care Navigation Program. Our program establishes an empowering environment to help improve the quality of life of those who have dementia or at risk of developing dementia, all while helping family caregivers reduce the stress and burden that often occurs while caregiving. At JFSA, we understand the importance in working with our clients' strengths and applying a person-centered approach to care, which extends throughout our multidisciplinary team of geriatricians, nurses, social workers, and geriatric psychiatrists. Nicole and I meet our clients where they are at and develop individualized care plans that produce solutions to presenting problems. From linking persons with dementia and their families with community resources to following them with their medical management. We are their point of contact for guidance as well as a listening ear. We consider the intersectionality of one's life when creating interventions that adhere to their biopsychosocial needs and experiences. A little bit of information before we start the webinar today. We will take questions and answers. So you will notice you have a Q&A box. Please submit your questions to that feature. You're welcome to do it throughout the presentation today. And I will get to the questions at the end of the presentation, and we'll take more questions at that time. We will be offering continuing education credits. So please note, it will take 30 days from the date of your application to issue your CE credit. So you will get a survey after our presentation tonight. It may take up a few days to get that. But once you complete the survey, that's how we know you attended the program. The email address that you use to access the webinar must be the same one as you are providing. So if you don't get the survey for some reason, just feel free to reach out and I'll make sure you get it. And if you enter a different or incomplete email address, it could prevent your CE from being issued. But again, just reach out and we'll make sure you get that. A little bit about our speaker tonight, Dr. Elizabeth O'Toole. She graduated from the Case Western Reserve School of Medicine and completed her residency in the internal medicine group with fellowships in general internal medicine with clinical ethics and geriatric medicine at UH and the VA. She has been a professor of medicine and bioethics at Case Western School of Medicine. She has over 30 years of experience in medical practice, focusing on geriatric medicine and palliative care, with an overall goal to provide patients and families with individualized care, education, and support. Dr. O'Toole has practiced at University Hospitals of Cleveland, the Cleveland VA, and most recently at Metro Health Medical Center, where she started and directed their division of palliative care and initiated the Hospice and Palliative Medicine Fellowship Program at Case Western Reserve University and Metro Health. She has worked and directed multiple externally funded research and educational programs. In addition, Dr. O'Toole has been involved in education and care through many community-based programs and has been a geriatric consultant for JFSA Cleveland for many years. And I will let Dr. O'Toole take it from here.
Okay. Good evening, everybody. Thanks for being here. Tonight, I'm going to talk about two kind of different and yet aligned topics, both of which were suggested by needs presented by some of our folks in the caregiver group. So I've touched on these in prior presentations, so hopefully they'll either remind you of something that you've heard before or give you a chance to think about it again. And if you have additional questions, this is going to be an opportunity for that as well, as Hannah said. I think one of many issues for caregivers, for folks who have dementia, is that caregivers may often feel that things are uncontrollable. And part of that is that things happen that are not planned, and things they appear more threatening because they're unplanned and concerning. And so we're going to talk today about some ways of thinking about things in advance of their occurrence, so that maybe that won't be so much of a, oh my gosh, now what do I do? But oh my gosh, here's the time for me to do what I was hearing about doing. I just need to get rid of something here so we can see it all. Anna taught me how to do this. Now I have to figure out if I can actually do it in real life. There we go. Okay, so the two circumstances I'm going to talk about tonight are challenging symptoms when they develop, and then serious unanticipated healthcare decisions that have to be made. What do we do about that? Both are times when people feel a little out of control. Hannah, can you shift it for me? Whoops, thank you. Oh. All right, so our overall objectives are to empower thoughtful management of some difficult circumstances, as we just discussed, that occur in dementia care. And those two circumstances are not things that are unlikely. They're things that will most likely happen. And that empowerment piece is important for you to think about, because this is not about forcing people to think about things that are not desirable to think about. These are issues that, because they're so common and will likely come up, having knowledge about them in advance, having a chance to think about them in advance, and having a chance to think about what should I do can take a lot of the fear and destructive emotions out of the circumstances when they occur. We're going to review some of those challenging symptoms and potential preemptive actions and responses. I'm going to ask you to consider these in regard to behavioral and psychological symptoms of dementia, which are really the most common challenging symptoms that we face. And then we'll review approaches to healthcare decision-making for late-stage dementia. Okay, Hannah. Thank you. As background, although there's nothing that we would consider really normal about dementia, I think we have to take a sort of a long view of the fact that this is not an uncommon situation. And we do have some information about all the different ways in which dementia presents itself, and what happens most often, so that we can take advice from others who've gone down this same road. And we can also recognize that that road is sometimes a crowded road. There's a lot of us feeling that they're dealing with this. The majority of those with dementia experience behavioral and psychological symptoms of dementia at some point. So it's not unusual. It shouldn't be shocking. Community dwelling individuals with dementia who have undergone assessment in longitudinal studies, now obviously, that's not all comers, up to 97% are affected by at least one of these symptoms. So this is not a situation where one should feel alone. Next slide. Some of these, which I'm sure most of you are well aware of, but I'll run the list just because we should. Wandering, incontinence, which means lack of bowel or bladder control, vocalizations or screaming, sundowning, which usually occurs late in the afternoon or evening, and is often characterized by patients being more demanding, more restless, more upset, more suspicious, more disoriented, seeing or hearing or believing things that are not real, and that this is something that isn't consistent throughout the day. It seems to just happen more dramatically at this late stage in the day. Next slide. Also includes agitation, which is a very serious symptom, which is problematic for both patient and caregiver, abnormal motive behaviors, anxiety, irritability, depression, or even apathy, just kind of not having any emotional response, delusions, often paranoid ones, hallucinations, sleep disorders, and changes in appetite. Next slide, please. The delusions, agitation, and abnormal motor behaviors, which can be somewhat disturbing to witness, fidgeting, repetitive behaviors, wandering around and not responsive to suggestions that different tacks should be taken, occur in about a third of patients. That's a lot of people. That's not uncommon either, of course. So as we said, sundowning is common, may affect up to 2/3 of people with the dementia. And obviously these kinds of symptoms do contribute to serious safety concerns. And safety is one of the things I wanted to emphasize as well tonight. Steps toward controlling. What can a caregiver do? What is the role for the caregiver? Well, history is important. And when these things happen, typically there isn't a professional observing to identify or to think about what might be at the core of this situation. So the caregiver who is present, unfortunately has to deal with this, has an important role in terms of this history. So what is exactly the behavior? So we call it, we meaning providers, agitation. That's a summary sort of title. It doesn't tell us what the person was doing. But the person who's right there, that caregiver, can. What is the nature of that behavior? Talk to someone about that, because it will help to figure out where it's coming from. What is the urgency of the need for intervention? Is this something that can be tolerated until it's over, or is this something that needs to be addressed right away? What are the characteristics of the symptoms? So not only nature of the behavior, when did it happen? What were the circumstances of the situation when it occurred? But what actually was happening? What do you mean by agitation? Is it restlessness? Is it confusion? Is it verbal? What exactly are those characteristics? And what did the caregiver or whoever was present or whoever worked with the patient thereafter, what did anybody identify as potentially reversible or exacerbating factors? So what was tried that made it worse? What was tried or that helped a little bit? Or what is thought about to be in either one of those categories based on what the caregiver, especially a family caregiver, knows about this person and what is important to them? What would flash them? What would trigger them to something? Okay, Hannah. The initial response to a serious behavioral or otherwise disruptive or disturbing symptom presentation is to remember to breathe. They can be very disturbing, especially when they're repetitive, but they can be disturbing because they are disturbing. But the first thing the caregiver has to do is take a breath. It's just it's a symptom. It might be scary because the person might seem like they're at risk, but take that breath, because if you don't and you just go ahead full force and do something, make some kind of response, it might not be the right one, and your own emotional response makes everything more difficult. Not that you're at fault for that as a caregiver, no, but knowing that if you take the second or two to try to get that recognized and under control, you're going to be much better able to deal with it. So breathe, step back, and think, is it safe? Because that's going to be your first concern, not correct what anybody's thinking or what they're saying, but is it safe? And then what are you seeing and what are you hearing? Those are where you're going to get your clues as to what needs to be done. What does the patient, I'm going to say patient because that's who I have to call these people, they're my patients. But I understand they're family members or they're the people you are taking care of. What are you seeing that they might be doing? Where might this be coming from their point of view? What are they saying? Even though it doesn't make sense to you, maybe there are clues there. What are you hearing in the environment? Are there threats in the environment that you know what that is? You understand that's the lawnmower outside, but they may not. So think about what the triggers might be. Okay, Hannah. So these are some of those symptoms that we mentioned before. And just a reminder, as disturbing as repetitive speech and wandering and sleep disturbances can be, they are all core clinical features of dementia. Not unexpected. So as frightening as they can be, this is something that is part and parcel of the disease. Okay, Hannah. Another issue that is important to think about when we see these kinds of symptoms develop is they can be associated with progressive functional decline. Certainly when they occur, from the individual's perspective, it identifies a worsened quality of life, at least in those moments. And as we all know, there is certainly increased caregiver distress associated with these situations. And sometimes this leads to nursing home placement because it can be managed at home sometimes not. Next slide. The early response to such symptoms, that is identifying underlying causes and appropriate treatment plans, are very important, especially when they're effective. They're important to try, but oftentimes they're effective. The sooner the better. Non-pharmacologic treatments are recommended as first-line approaches. So many folks are hoping and expecting that there's going to be a pill or some kind of medication that will transform this whole situation. And truthfully, sometimes we do end up, because of various circumstances and after much conversation, treating with medications. But the primary goal is to improve the quality of life for the patient and the caregivers and their satisfaction. So we try to avoid medications because there's no medication that has there's no harm going to happen to a person just by taking the medication. They all have risks. Okay, Hannah. So again, these are some of the things that we count on the caregivers for. What feelings seem to be happening for the patient? These are assessments of the patient-related factors that affect that behavior, and they can include feelings. So were you seeing sadness, fear, stress, more confusion or anxiety? Because oftentimes when these folks end up in the office, none of this is present at that time, or if the agitation was so severe, you wouldn't be able to get them to the office. So these are the things that we need to understand. So anybody who can help us identify these things in this individual, that's extremely helpful. And they tend to be recurrent. So if agitation occurs in this circumstances at one time, it may well be the same sort of circumstances when it occurs again. Physical or health-related problems, what's the story with that? Is there a complaint of pain at times? Have there been new meds introduced or a change in the meds that were usual? Has sleeping been a problem of late? Because sleep deprivation is a problem for folks with dementia, just like it's a problem for everybody. And obviously, one does need to seek medical evaluation if there are any physical or medical concerns. If there's a fever or there's a cough or there's some kind of sputum production or there seems to be pain in some place in the abdomen or the chest or anywhere really in the body, if there are some things that trigger the caregiver to suggest there might be physical or medical concerns, then medical evaluation needs to be taken in a timely fashion. Was there a possible injury? Does this patient seem to be infected? Is there a urine problem? Has there been a sudden change in the behaviors associated with that? Constipation? We think of constipation in society as something you see a commercial on TV for, and you take something and that's that. But it's actually quite a problem for a lot of people, particularly who take various medications for which that's a risk, or if they have an abdominal, a change in their abdominal process, or GI process, which is causing it. Hunger and thirst, which a lot of patients with dementia cannot express as such, and agitation may be their way of telling us this. Problems with vision or hearing. You can imagine if you can't see right, you can misinterpret what you do see. Same with hearing. And it's scary when things are going on and you can't hear. And assess for environmental issues. And this is an important piece, because we're used to the environment that people are in. The dementia patient has been used to the environment that they have been in, but subtle changes to us may be major changes to them, like too much noise. Because of their hearing, now we have a very loud TV and a radio. Or we have more than one person who's now agitated as caregivers because the patient has become agitated. And we're talking at once and too loudly, what are we going to do about this? And processing it, which doesn't calm the patient down. Interestingly, light is very important. Is it too light? Is it too dark? Are they jarring? Whatever's going on, is the too dark too scary? Is the too light too upsetting? Has there been a change in the environment? Or has the patient just noticed it a change or been more sensitive to it? Is the floor level? Because if the floor isn't level and the patient just realizes it's unstable, it's destabilizing. Or there are patterns with changes in vision. For example, patterns on the floor can become scary. You don't know what's actually level and what isn't. It's confusing. Is the surface type change, going from rugs or carpets to hardwood to like tile? Those can be seemingly like you're stepping off into something very different. That's concerning. Mirrors are not what we are used to thinking of them. Reflections are not processed necessarily as reflections. They're strange people or they're strange things. So think about those kinds of things that can be triggering in your environment. Okay, Hannah. For the wandering and agitation, think about those surroundings that might be changed to allow more freedom. So it's not so much doesn't become wandering and patient doesn't feel trapped, but they are safer. So pay attention to dangerous items. Pad sharp corners, for example, get rid of clutter. Lord knows my house would have to be completely redone. Taking care of my 10-month-old grandson, he has found, now that he can sort of semi get around in a vertical status, he has found places you can get into trouble in my house I never knew existed. But so I can imagine that this is even more difficult for our patients or our family members. Things that you wouldn't have considered are dangerous are in fact dangerous. Pad sharp corners, get rid of clutter, mark edges of steps, particularly with vision is a problem, or depth perception. Sturdy handrails on stairs. Remove small throw rugs are really hazardous. If you have rugs, hopefully you can get non-skid backing and have patients or individuals wear sturdy footwear so they don't slide around. Next, Hannah. Interestingly, even in very agitated states, not always, I understand this, been there and I've witnessed this, but reassurance for the person by using calming phrases when the last thing in your mind is thinking calming phrases and letting the person know you're there. I'm here. Let's think about this. Allow adequate rest between stimulating events because that sometimes escalates things. Use lighting to reduce confusion and restlessness, especially at night. So low-level lighting, depending on their vision status. Involve the person in activities such as art, music, or therapeutic touch. to promote relaxation. Also, if you can get people who are confused and agitated and upset to shift gears to another topic or to get involved in something else, that's not always possible, but sometimes it is. Simplify tasks and structured routines. Yeah, complicated things only make people feel inadequate and frustrated when they can't do them. And that can change. So something that people could have been doing without much difficulty, some days it turns out they can't do that anymore. Find outlets for their energy. We all have hopefully some energy, such as taking a walk or doing household chores or meaningful activities. Folding things seems to be something that is repetitive and calming and people can be successful at it. And use signs and labels if the individual is capable of responding to them to cue or remind the person of what things are, where things are, whatever you think would be helpful. Thanks, Hannah. Other safety issues in terms of assessing for potentially dangerous items in the environment are medications. Now, we have to put these in safe places, not just prescription, but also over the counter. Dangerous chemicals, which aren't always what we would view as dangerous. They don't always have this little skull and crossbones things on them. Household products, laundry detergents, matches, obviously, anything flammable, sharps. You can think about weapons, including knives, scissors, tools, and machinery. Poisonous plants, sometimes I don't think we're aware of what plants are in fact poisonous. And sometimes it's the flower part of the plant, some it's not. So we can pay attention to whatever plants we have. Alcohol and other intoxicants clearly are a problem. Even home normal things. A wonderful lady who was wandering around in her house thought the cooking oil was, and if you think about what cooking oil is stored in from the store, it looks like it would be a bottle you could drink out of. But obviously guzzling down, that sort of thing would not be good for somebody. So be creative in thinking about what might be a potentially dangerous item and where putting it might be safer. I also want to mention, if you're not aware, there's something called a home safety evaluation, which if you talk to your provider or somebody in the program here to help you figure it out, it's done by a therapist, like a home care therapist, and it's ordered by the provider, and it can be very helpful. They'll go to the home, they'll go through the patient's day, they'll go look at the patient and what their activity capabilities are. And they'll also look at what's there that could present a threat. Simple things like having a medical alert is one opportunity, but other things, stairs, what's within reach, what isn't, what is the patient's, what do they do when they're at home? Do they walk around? Do they sit in the same place? What are they doing? This is bathing, etc. This home safety evaluation can be extremely helpful. And in fact, even may recommend things that as caregivers we might think about, and maybe they're great ideas and maybe there's a better idea. So home safety evaluation can be done. There's also a speech therapy evaluation for folks with dementia. Maybe you've been involved with some of those. It's not so much about being able to articulate speech like you might need after a stroke. It's about the memory issues and what are strategies to help get through the day given whatever problem that individual is experiencing. Those are also done at home in the patient's normal environment. Okay, Hannah, next. As we've discussed, changes are expected. That's one of the things about dementia. It is a progressive, it's a process. We have to remember as this changes over time that we have to, we, meaning all the providers, all the people involved with the care of the patient, families, the approach has to be patient-centered throughout. It's very easy. There are other people involved. Caregivers certainly experience things that need to be treated, recognized and treated, responded to. But the bottom line in treating dementia itself is to be patient-centered. And it's very easy because it's such, it's a disease that so affects everybody around the individual, that sometimes we have to think about that, because the patient, as we know the patient, or we have known the patient in the past prior to their disease, is in fundamental ways, not totally, but in fundamental ways, becoming a somewhat different person. Caregivers who know and care about the patient are uniquely able to be helpful and interpret appropriate responses. Because although people change, who they are as at their core, what's important to them, what triggered them in the past, what's their history that they might flash to, all those things caregivers know, at least family caregivers know, and are so important. So we need to take care of caregivers as well. We have to help them to be, it's so natural to be reactionary to things, to help people to slow down a bit, to attend to what might be the patient's history and experience of whatever situation has occurred. I've mentioned this before, I hope you don't think it's silly because I think it's critical. Smile. A smile can be understood even with severe impairment or distress. There are a few things that bring joy to what I do for a living. And one of them is this. When I have somebody who's so lost, but they can respond to this. They can respond to a smile, which tells them at some level, this is a person I can try to interact with. They somehow see me as not a distraction, as a problem, as much as everybody else seems to. They see me as a person. And of course, attend to the environment and safety, which we've already talked about. Thanks, Hannah. So in terms of potential responses, non-pharmacologic interventions are recommended. Some medications are used when these fail, and symptoms are only when symptoms are extremely burdensome or even dangerous. Those decisions are made on a risk versus potential benefit evaluation and involve, obviously, family and the provider. Antipsychotic meds and some others that are used in this context are potentially negative, have potentially negative side effects, including an increased risk of death. Therefore, obviously, they're used carefully, or they should be. They may be helpful, but remembering that they're not going to change the underlying illness. Thank you, Hannah. Caregivers need to attend to their own health. That's important for us to remember. And ability to tolerate the stresses and issues they encounter in dementia care. Sharing burdens when possible is helpful. Not always as possible as we might like. Caregivers should seek assistance with strategies and coping when they need it. Remember that the behaviors are the result of the disease and not volitional on the part of the individual. Some things that are said that can be heard as very cruel and very upsetting, but they don't come from a place of wanting to be cruel or wanting to upset. They come from a place of not understanding and generally fear and upset on the part of the individual. And when such behaviors occur, we have to evaluate and reevaluate, because both the behaviors and the abilities of the individual, because those change over time. Okay, Hannah. I'm just going to take 3 seconds to look at this because it's so cool. We're going to switch to the other topic now. And this is about healthcare decision-making, which I'm sure you've all heard about, but for some reason, it is a source of confusion for a lot of people. Even people who say, I ask almost everybody in clinic for sure. And I did when I was doing consultation in the hospital as well. Do you have anything to talk about health? Have you had any conversations or have you done anything about healthcare decision-making in serious illness? And people say, oh, yes, I fill those documents out. Oh, good. What do they say? I don't know. I signed them. Okay, that's good. I'm glad you signed them. But what did they say? What did you want them to say? Where are they? And how accessible are they? Because if they're in a drawer, in a desk, or they're in a bank, or they're in your lawyer's office, they're unlikely to be useful when they're needed. So making healthcare decisions in late-stage progressive disease, which isn't only dementia. Dementia is one of those late-stage progressive diseases that this is important. Heart disease, vascular disease, all kinds of diseases. They're often difficult and challenging, and that means they have to be thought about carefully. Too often, serious healthcare decisions in late-stage disease are made in crises. Way too often. I used to get called on these all the time. And it wasn't that people hadn't really recognized, people didn't want to recognize the situation, or people couldn't deal with having the conversations. It seemed too upsetting, or there were other objections. So they end up happening in crises, when being in control to make thoughtful, careful decisions is not often possible. There's just drama everywhere. Understanding some common situations and options in decision-making may facilitate consideration of patient and family wishes to make thoughtful and respectful decisions. Okay. So what are the 3 common advanced directives? Meaning directives for actions that should happen in advance of the time when they will happen. There's a living will, there's a durable power of attorney for healthcare, and there's a DNR order. And we need to talk about these in the context of Ohio because they do vary from state to state. Okay, Hannah. Oh, there we go. So what would our plan be? We're going to review common end-of-life medical issues for dementia patients and causes of death to facilitate thinking about decision-making. Review perspectives in considering late stage of life and reasons to give consideration earlier to healthcare decision-making. We'll discuss those advanced directives in Ohio and hospice considerations. And please remember to tell us good questions if you have them. So understanding the perspectives, that is, physical symptoms, the emotions, the beliefs, the goals, and other contributors of those for whom we make decisions, as well as our own perspectives, are important to consider. Those may not be the same. That doesn't mean that we shouldn't consider both, but they may not be the same. And ideally, the perspective we want to honor most strongly is that of the individual. But unfortunately, in dementia, things change so much over time that unless we really get those clear before the person lacks capacity, and at that time they understand that at some point they may not have capacity, and what would they think about that? If we have that opportunity, we need to take it, I think, because those are important. Also important perspective for patients who have no longer got capacity is, what is their life like? What is their quality of life like now and in the future if something happened? And what would they, if we can, think about that? Clearly, neither one of these things requiring such careful consideration and thought is best done in a crisis. It's just not best done in a crisis. Do we make them in crises? Of course, we have to, but it's not ideal. And it is wonderful when a family comes in and says, oh, we've talked about this. We know exactly Dad would want. Context to think about. Ultimately, this life is temporary. There's nobody who gets out of this life. I mean, if they get out of it, they're out of it. So although nobody wants for anyone we care about to die, or for that matter, for anyone to die, it does happen, and it will happen to everyone. So that is the context in which we live. It doesn't have to make us sad and distraught, but it is a reality. However, much of what happens to us is, and unfortunately, much of what happens to us is not in our control. There's nobody wants dementia, for example. Nobody wants their loved one to have dementia. Nobody asks for that. It happens. Lots of things happen, not in our control whatsoever. However, how we deal with what happens to us may give us an opportunity to make choices that are most consistent with our beliefs, wishes, and caring for each other. Yeah, there we go. So advanced directives, if you remember those documents I mentioned, they've been around for a long time. They were brand new when I was in training, or got out of training, in training. And it's happened with the Federal Patient Self-Determination Act of 1990, which requires all healthcare facilities to provide all patients upon healthcare program admission information about the laws in their state regarding the documents that I mentioned: durable powers of attorney for healthcare and advanced directives. Next. We don't have to go into this in any kind of detail. I think people are pretty well understanding that this is true, that the facility has no interest in promoting advanced directives, although they will facilitate them. But they do have to provide the information if you ask them for it. They do have to have a policy regarding them. They do have to give you the forms, and they do have to keep records of any advanced directive that you provide them with, which in the land of electronic medical records is a very good thing, because it becomes in the medical record and it's scanned in there. And so it's, one can find it, which is not the way paper happened. Okay, next. Much better to have those advanced directives there than in a lockbox somewhere. I just put this in because some of our folks are old enough to have already enacted an Ohio Durable Power of Attorney for Healthcare and Living Will document prior to 2016, when they subtly changed the documents. It doesn't invalidate the prior forms at all. Issues specifically addressed in law are that patients have a right to options under conditions of permanently unconscious state or terminal illness and can't make decisions. If the patient can make a decision, obviously they can't if they have permanently unconscious state, but if they can make a decision, then they make the decision. Decisions may involve initiation, withholding, or withdrawing life-sustaining treatment, including withdrawal of artificially supplied nutrition and hydration. That requires a special effort on the part of the person who's signing the form. Next. What's the key thing in terms of identifying who's going to make decisions for someone, which is really important in the case of dementia. And unfortunately, early dementia, when persons may still have this capacity to choose, allows the opportunity for this to happen in a formal way. If we've missed that opportunity because the person no longer has capacity and they've never signed anything, it does, however, give us a chance to think it through with the folks who would be considered the hierarchy to make decisions for people, so that we can get them, if possible, on the same page. Ohio law provides for this hierarchy of patients who have not designated a healthcare proxy. That includes a guardian, spouse. The guardian is automatically that person. The spouse is automatically that person. Adult children, that's more dicey. In urgent cases, if you can contact somebody and if you can get somebody to respond to you, or get some people to respond to you in a reasonable time. That works sometimes. But in general, we try to get the majority of children. Now, that depends on how many children are involved, how much of a arduous task that might be. Although with 2 children who don't agree on anything and haven't in the last 50 years, that's not a good situation. So any situations like that, and you know these kinds of decisions are going to come up and there's no other identifiable person, it might be time to try to approach each other and see what one can do to engage. Failing, having adult children who can do it, there are parents, siblings, again, a majority of the siblings. So these are opportunities to, if this is what looks like what's going to be the story, to try to get folks on the same page, or at least to be civil to each other so that decisions can be made. Yeah, okay. Ohio law does not authorize, some people get very nervous about this. Ohio law does not authorize euthanasia or assisted suicide. That is not okay. Physicians are not allowed to do that. Hospitals and physicians are not required to withdraw life-sustaining treatment when such decisions are in conflict with the physician's conscience or hospital policy. Also good to know. It doesn't mean it can't be done if it seems to be a significant desire on the part of patient and family, but it's okay for a physician to say, not me, I'm not doing it. You can have an ethics committee come in or somebody else and find somebody else to do it. Physician in hospital cannot block transfer of a patient to another facility if another facility will accept the patient. And unfortunately, I think patients and or families sometimes think that you can just say, I want to go such and such a place from one hospital. Transfers from hospital to hospital can be complicated, especially if the patient is, unstable. And so they would require records from the hospital to see what the status of the patient is. And sometimes they'll say, no, we can't take this patient. That doesn't sound like we would either do anything different or that it's a stable transfer, or for whatever reason they can decline. Next. The durable power of attorney for healthcare. That's where the patient gives somebody else, a patient with capacity, appoints someone as their agent to make healthcare decisions for them, should they lose the ability to make decisions for themselves. This can happen temporarily or can be a permanent loss of capacity. The updated form allows patients to give the agent access to their healthcare information prior to loss of decision-making capacity. It's a checkbox kind of thing they have to sign or initial. They may state their wish or give authority to avoid artificially provided fluids and nutrition. Artificially provided fluids and nutrition are things like nasal gap tubes down the nose and into the stomach to provide nutrition, or a small surgical procedure through the abdomen to put that same kind of a feeding tube directly into the stomach, or even intravenous, which is a more tricky thing and not a real long-term solution for most people. These tubes can potentially be a lot more longer-term solutions if that's something that is going to gain the patient something they want. They're not always desirable, and they're not always effective. They have several risks associated with them as well. Next. Living will applies to individuals in a terminal condition or a permanently unconscious state. So while the durable power of attorney for healthcare gets you a person to make decisions in your stead, this tells what you would want under those 2 specific circumstances, your direction, you as the individual. Other documentation may give valuable evidence of the patient's wishes, but doesn't have the same legal standing as the proper living will. Next. Comfort care is a phrase that we use a lot. It basically means administering no life-sustaining treatment, including CPR, and focusing on the patient's comfort. So all our decisions should be made in terms of treatment based on, is this going to make the patient more comfortable or not? DNR orders are similar to comfort care in that but they're more specific. Take no action to postpone my death to providing me with only the care necessary to make me comfortable and to relieve pain in the event of a cardiac arrest. If it says DNR CC, do not resuscitate comfort care. A, that's in the Ohio form, means in case of a cardiac arrest, case of an arrest, do not do resuscitation. Provide me only with the care necessary to make me comfortable or to relieve pain. The other form, next slide, please. Oh, we don't have it here, sorry. Is do not resuscitate CC, which stands for comfort care, which, as I just mentioned before, means that every decision, not just an arrest, I mean, every situation, not just an arrest, but every situation, each treatment should be considered and decided upon as regarding whether it would advance the comfort of the patient or not. If it's not, if it's to find out more information, if it's to treat some disease that's not really going to make the person comfortable, like a surgery, then the answer would be no. DNRCC and DNRCC arrest. Okay. Next. Just FYI, living wills also have organ donation and they're also durable powers of attorney of healthcare are sometimes associated with them. That's like one long document. And this is what we talked about with the do not resuscitate. They're triggers for initiation of this comfort only care. Arrest, DNRCCA, immediately, DNRCC, and thereafter. And these documents are portable. They should be adhered to no matter what healthcare institution you go to. And especially with the DNR, where are we now? Especially with the DNR, those are portable. So it's a form, it's unlike living will, which is the patient's wishes, the POA, which is giving a decision maker, the DNR order, resuscitation, do not resuscitate, is an order directing care. And that's a form, an order form, and it's portable. You should, if you have one, if someone has one, they should have one at home, preferably on the refrigerator, so EMS would find it, and every place that they go to for a healthcare point of view. They're signed, DNR orders are signed by the provider, and they direct care. They're good at home, they're good in a facility like a nursing home, hospitals, EMS, ambulance, etc. Next. Compassionate, comfort-oriented care. This is palliative care we're talking about now, because it's a confusion between people have between palliative care and hospice care. Palliative care is sort of a description of care that includes hospice care, but can and often should be given much earlier than hospice would be available. It's compassionate, comfort-oriented care addressing physical symptoms, physical and mental stress related to a serious or life-limiting illness. So it's broader than a terminal illness. May be appropriate at diagnosis, along with curative care efforts. You can go in tandem with those and follow up, and also at end of life. It's received from a palliative care provider, and for physicians, hospice and palliative care is also a board certification in conjunction with the patient's other healthcare team. And the payment is covered as other medical services are covered, like any visits to a specialist. Next. It's appropriate for patients with late or end-stage disease, including dementia, and it's provided by it can be provided by an individual or a provider or a certified hospice organization. They sometimes will also provide palliative care in addition to hospice services at different times in the patient's journey. What's the advantage to hospice care itself? With palliative care, people transition often into hospice. Sometimes people don't do the palliative care route. They just go directly into hospice when it's time. There's a hospice team that's required. There's a lot of federal regulations that govern hospice. provides a multidisciplinary approach. They have to have a nurse, a social worker, a spiritual care person, and a physician. They have to meet every couple of weeks, and they have to sign off on the plan of care. And they have to be available for consultation if there's some change in the care, patient situation. It can be provided in the home or in a facility, wherever the patient calls home. They have respite care, which is part of their deal, which was a nice feature, which means they provide care for certain periods of time at certain intervals for the family caregiver to get a break. Care is provided for comfort, including related meds, equipment, supplies, and typically covered by insurance. So 100% for those things I just described. Care for ongoing other diseases may not be covered unless needed for comfort, and the assistance to the caregivers unless it's absolutely necessary. So something to think about, something to talk about in terms of what other disease processes the patient is facing and what you're comfortable not being as aggressive in terms of treating. Hospice is available for home visits. They have to do them at least routinely on certain intervals. And they will also be available by phone. And if they need, they will come and check things out or come more frequently. Next. Hey. Okay. So we covered a lot of stuff. We covered some symptoms, disturbing symptoms, approaches to some of them. We covered decision-making and considerations earlier considerations and setting people up for successful management of this journey. And here we are now. Any questions?
Right, everyone. We'll take your questions in the Q&A box as well. So I'm just gonna. Here are resources. And as always, we do send out the slides, so we'll share this with everybody. What if my loved one is having behaviors and I can't get her to the doctor? You know, she won't go. How
Yep.
do you address that?
I mentioned, when I was talking that the caregiver who's facing this at the time of the behaviors, is experiencing something very different from what I would see by the time the person comes to the office. And that's absolutely right. I mean, sometimes agitation is intermittent and there is opportunity in between, but it's worrisome because from the caregiver's point of view, you never know when that's going to happen if you don't have a clear trigger. So home visits, home assessments are possible. Hannah, you could make some suggestions about what you think about that. Sometimes the care navigators will help talk about those things, and we might troubleshoot in conversation. If it's my patient, I don't know about what with other persons, other care providers.
Right.
But if there's the speech therapist, for example, isn't so much about agitation, but they can sometimes get a bead on what's going on. Certainly a phone call to describe what you're seeing is useful when it's happening. All those questions that I put in here, if you've got the story and you can get it together to be able to do that, that helps. If it's because I know as a provider, if it's somebody I know they have dementia, I know they have a risk of this sort of thing happening, and I have somebody's telling me a good story about what is actually going on, that I sometimes can make a decision. Maybe I'll send some out for lab tests to evaluate for infection or the other things that might pop into my head. And we might actually make some other suggestions. What do you think, Hannah?
I definitely think if you can bring in services into the home as best as possible, at least coming into their environment where they're comfortable can certainly help a great deal. kind of going back to the behaviors, something I notice a lot with our clients, Dr. O'Toole, maybe the client comes in, but then the family member can't or isn't comfortable discussing some of the behaviors that they see a lot. So
In front of the patient, you mean?
right. So, with us, we've made separate phone calls with you and the caregiver, after the appointment. I think at times people will journal or take notes of things and kind of share that with the doctor prior as well. Do you appreciate that kind of communication, Dr. O'Toole, with how people?
Absolutely, absolutely. And I understand and appreciate the difficulty of actually telling,
Mhm.
recounting in front of the individual. Because it isn't, they feel affronted by that sometimes.
Mhm.
Sometimes they don't even know what you're talking about, but sometimes they do feel
Right,
bad about it. So I think that's a good point.
right. We have a program, of course, at JFSA where geriatricians come into the home, but there are also other visiting physicians as well. But we always tell people if it gets to a point where something is truly wrong, it's an emergency, you can always call 911 to get someone immediate medical help too. But, we try to make people comfortable. It's all about building a trust and rapport with the patient. So, sometimes you just have to be, it takes some time sometimes. So that was a good question.
Yes.
Um, Someone wrote, if someone hits their head after a fall, will this increase their dementia symptoms permanently?
That's another good question. I didn't go over today the causes of death listed on death certificates when they do a study on patients who had dementia. And it's usually something else. Dementia's in there, but it's usually, heart failure or some other medical problem that reached end stage, lung disease or whatnot. But fractures and falls are high on the list. Head injuries are common. And some people are on blood thinners, such things. So when you hit your head on the floor or anything else, really, it's not good. If the behavior change is associated, if there's some changes in behavior also associated with the fall itself, certainly it needs to be evaluated. I mean, people have bleeds in their head. Sometimes those are permanent, sometimes they recover depending on their situation, but it is a definite concern. And that's why everybody gets a CT like that. Not everybody, most people would get a CT and the ED for that.
How important is the patient's history in predicting problem behavior?
I'm not, if this is a problem person, you mean? A person who was
Or I'm
agitated before they
wondering,
had dementia?
maybe, I'm wondering when I read that, maybe mental health, potentially history, or does any of that lead to behaviors later on in the disease?
It can, pre-existing psychiatric, mental health issues, those don't go away, but inhibitions may. So whatever control had been going on might not be so great. Anxiety and depression, who much might predate the progressive dementia. Now the normal cues that kept people managing those things in addition to their medications perhaps are no longer available to them. That can cause problems. And other medical illnesses can also be possible. I mean, people with hearing deficits and vision problems that progressed, or they can't stand to have their hearing aids anymore because they don't understand what that's about, or they don't like wearing their glasses, and now they're losing two key senses to try to right the way they see the world. So lots of things that happen and that are part of the history can also be part of their dementia. People have had major trauma in their history and have, without doubt, worked hard to get that in perspective. And what happens in dementia a lot? People recent memory is that is more affected than long-term memory, right? So people are talking about when I was a kid, or, when I was a young adult, and that was exactly the time when this major trauma might have occurred. Um,
Yes.
and it's a big concern for people caring for them because it's tragic. They've overcome so much and now they're right back in that scenario, and it's really very difficult. You can't, there's no therapy, talk therapy is not going to work for that, for this population. We do sometimes consider medications, but it's sort of hit or miss because there's side effects. It's a very difficult thing. If that's what you're referring to, that's very challenging.
Yes. Yes, that's a very good point when you bring up trauma, and it's very unfortunate sometimes that dementia patients go back to the younger days, and that's exactly when those traumas might have occurred. Um, Someone just wanted to share they're going to begin working with a new doctor soon. And their husband is the one with the diagnosis. Well, their husband is the one seeking diagnosis. And for some reason, it has been difficult to get it since my husband is not cooperative.
Ah,
Um, this is and
interesting.
has been frustrating due to his behavior. Um,
Hmm.
do you have any suggestions on how to get help? It sounds like this person has been to several doctors, and seeking a diagnosis has been difficult.
So it's not so much that a diagnosis couldn't be made, it's just that the patient is not in a state where he's able to go through the process of having the assessments to make the diagnosis. Is that right?
So that could be, and
That could be.
possibly maybe some of the doctors are not all on the same page, as I maybe
Ah,
gather.
well, it is a challenge when, you see a patient and they present one way, and then somebody else sees a patient and they present another way. And you think, how is it possible that that doctor thought so differently from how I thought about that patient? But
Mhm.
because that's what they saw. And I can imagine how frustrating that must be. But it sounded like the patient wanted a diagnosis, but then sort of blocked the process. Um, or did I hear you wrong?
Maybe possibly.
Okay. In which case, if the provider knows that, and they may have, and they may, if the patient still has the capacity to understand what's being said, if they want a diagnosis, it's very interesting. I would want to know why they want the diagnosis, what they think the diagnosis is. And if they really do want it, this is what we have to do. Where is your, if you can possibly answer, why won't you do what I'm asking you to do? What's the objection? And I'm sure they all ask that. But it would be interesting to know that. And it sounds like maybe this person who's asking the question was asked to not be in the room at the time, so she cannot be anything but just frustrated by the whole thing.
Can be very frustrating.
I mean, there are some assessments that one can do. We do some very basic assessments that aren't, but person has to sit and answer questions that they may not want to do, like,
Right.
I don't know, sometimes you can connect with a person, and if you can find if the person can get to what his real concern and worry is, and just address that up front, that might be, if he's capable of responding to that, that might be one avenue, if it hasn't been tried.
Mhm.
It's scary stuff.
It is. It is. Um, one of the questions, or actually, I get this a lot from families, they, for the advanced directive side of our discussion
Mhm,
today,
mhm.
sometimes their parent does not want to discuss the future, or, they don't really want to think about getting things in line or in order. Do you have any suggestions for the family? Because I'm sure you have people coming to you about that topic. Do you have any suggestions for our audience about how to encourage the family to get things in place?
Yeah. Well, I'm a big proponent of getting things in place, but I recognize some people just are never going to get there. But even if they don't get to getting things in place, if somebody, even if somebody doesn't get documents in place, but they have a serious conversation, they can relate. And those are good and important pieces of data. Family meetings or like, I don't hate to say around the Thanksgiving table, it hardly seems like, but a lot of people do this at those times because the family's together. That's when they're people who are more interested in the empowerment part than the content of it. So you could ask, I don't know if they've done this with the provider who's just doing it, making it a routine thing. This is important. We always discuss this with our patients. I haven't singled you out because I think you're in deep trouble.
Mm.
So the anxiety level doesn't have to be triggered, is to be high.
Mhm.
Who do you want in the room? If we talk about that, you came with your wife. Um, wouldn't she be an important piece of that? We all want to know what you think about things, and the provider can make it more of a clinical thing than an emotional thing sometimes. Which is sometimes takes a little bit of the sting out.
Mhm. Mhm.
Depends on the person's cognitive abilities, of course. But a clinician can respond to whatever the response he gives or she gives us if it's a different person. Um, but I think those are opportunities
Mhm.
to make this normative. This is what we do. It's about respecting you. So tell me, what do you think?
Mhm. Mhm.
I don't know if that's helpful or not, but that's given what this question told me, that's what I would think about.
Yeah. A way to encourage them to start thinking about it, I think is,
Yeah,
you know, and you make a very good point in your slides that you want to do it at a time when it's not a crisis,
yes,
because you're really not making maybe the best or the decision you really would have wanted to make for yourself or your family member at that
right.
point in time. So,
And typically in a crisis, I mean, I worry sometimes when I put that out there for patients who really aren't excited about being engaged in this at all, because they are likely to say, I'll wait for the crisis because they won't have to ask me.
they won't have to be, yes.
Because I'm not going to be a component of that. But I
Mhm.
mean, most people would not want to burden their family that way.
Right. Right. Thank you for that. I think we have time for one more question. Okay, here we go. I am seeing a lot of commercials for the Rexulti
Mm,
medication.
hmm.
Can you talk about that and how that's different from other, um, you know, memory medications that are out there?
Yeah, it is new. It's an antipsychotic type. It has those same warnings that I talked about. Um, and it's usually given, it's actually, its original use was as an adjunct to an antidepressant for people who have um, serious mental health problems anyway. So
Mm.
it was an adjunct to their already in place medical treatment. This
Mhm.
use in dementia is new. I honestly have not used it yet. I'm looking at, how to, I mean, I'm following the literature because I can see it might well have a use. Because as we know, people are struggling. So I can't give you a definitive answer on that, but I think it's very important to think it through.
Mhm.
And I think it's not something I would want to reject. I would want to think about whether it's appropriate in a certain instance. It's certainly not our go-to yet,
Okay.
but that can change. It may in this case.
Is it similar? I know we've talked before, some of those medicines that are out there for mood, just well, used for mood disorders, but can be used for dementia, like Seroquel and some of those other
Yeah,
ones.
yeah,
Is
yeah.
it in
It's a
that
little,
same?
right. It's a
Okay.
little bit different from that, which is not a bad thing.
Mhm.
Especially, and it's interesting because they seem to have done some work to look at it in this situation, not say, well, it works in agitation for other things, let's try it in dementia. I think they've done some work to look at how effective it could be in dementia, which is,
Someone did share just now that their brother, who has Alzheimer's and history of a TBI, is
yes, that's
doing it.
exactly right. That's the scenario that it's really been,
And it's very expensive, someone added.
I'm
So-
sure, of course. This is one of the other challenges. First, we have to make sure people are safe, and
Mhm.
then we have to make sure people are safe
Right,
from poverty.
right,
Be
right.
really, and to say that we have something, but it's too expensive seems so wrong. You know, it just doesn't seem, well, that's an editorial comment, not best done here.
All right, well, thank you, thank
But
you.
I'd be happy, yeah, we might think about what to say about that the next time we talk.
Right, we can certainly delve into more of that.
Maybe that would be a good idea. Thank you for the suggestion.
All right, everyone. Well, thank you, Dr. O'Toole, for your presentation today. And as I mentioned, we are recording this. Some of you I did notice got in a little late, so we are recording this and we will be sharing this as well as the slides. So we shared a lot of important information today and hopefully helpful.
We could mention that the Ohio documents are available at ohio.gov or the Ohio
Yes,
Bar Association.
yes, exactly. If you are looking to get those advanced directive papers for Ohio, they are accessible online, they are free, and I'm happy to share that too in our email, how to access them. All you have to do is download them. You either get 2 witnesses to sign that aren't family, or you can get it notarized. Some people also opt to go to an attorney if they want something special, you know, that they have questions about, but it's very easy to do if you need a basic document. So again, Nicole and I are here. We're part of the dementia team. If you have any questions about your family members, we're here, and we can point you to various resources. Our 2 geriatricians that work with us, obviously, Dr. O'Toole, and then we also work with Dr. Magulius as well, and they come to us at our JFSA location on Chagrin. Also part of our team is Pamela Lynch. She is our facilitator for our support group and as well as our Caregiving with Confidence workshop. And new to our team is Carol Klingler. You will be seeing her on our brain health and wellness presentations, so stick around. She will be with us, I believe, starting in March. So we're very happy to have her with us. In summary of our resources, we offer Caregiving with Confidence workshops, which we just started one. So we will be offering more throughout the year. We have our bi-monthly support group, of course, the help from Nicole and myself, our home care program, which Dr. O'Toole mentioned about home safety evaluations. So we do have a department with skilled services such as nursing and physical therapy that could come out to the home if you are looking for an assessment of the home. And then, of course, our brain health and wellness initiative series. Next month, Dr. Grossman will be with us on February 22nd at 6:30, presenting on loneliness, depression, isolation, and dementia. And then here's my contact information if you feel free to reach out to Nicole or myself. So thank you everyone for coming tonight, and thank you, Dr. O'Toole, for your time.
Thank you all.
All right, take care, everyone.
Bye.
Bye-bye.